In acute clinical settings, severe symptoms rarely map perfectly to a single disease. A patient crashing with fever, tachycardia, and respiratory distress presents a chaotic picture where overlapping physiological failures mimic one another. Relying solely on the presence of these positive symptoms can lead to misdiagnosis. Vastly different underlying pathologies, from systemic infections to mechanical obstructions, often trigger the exact same alarms in the human body. This sectoral diagram represents a differential matrix. It is a logical framework that requires a clinician to weigh the evidence for a specific diagnosis against the evidence for its mimics. It forces an evaluation of what is present alongside what is missing. Notice how the pathways shift. The presence of a single, highly specific negative finding immediately severs the connection to a plausible clinical mimic, narrowing the diagnostic possibilities. Mastering this systematic elimination process reduces diagnostic uncertainty. It provides a clearer map to align a medical intervention with the true underlying pathophysiology. When host antibodies detect incompatible donor red blood cells, they bind to foreign antigens, triggering immediate, violent destruction of the cells within the vascular system. Consider a 25-year-old postpartum patient with sickle cell disease. Shortly after receiving a unit of packed red blood cells, she develops flank pain, a fever of 38.5 Celsius, hypotension, tachycardia, and dark brown urine. This matrix maps her presentation. Hemoglobinuria with flank pain points to an acute hemolytic transfusion reaction. Her normal oxygen saturation strictly eliminates TRALI and TACO. No urticaria rules out IgA deficiency. The rapid onset and lack of surgical infection remove puerperal sepsis. The immediate management protocol is clear. Halt the transfusion, provide supportive care, and confirm the antibody presence with a direct Coombs test and hemolysis markers like elevated LDH. Recognizing alloimmunization as the specific mechanical failure dictates this exact response. Treating the fever or blood pressure with antibiotics or diuretics without stopping the transfusion would fail to address the primary insult. A 17-year-old boy presents with a 6-month history of extreme fatigue on school days. Despite getting into bed at 11 p.m., he cannot fall asleep until 2 a.m. The diagnostic signal lies in his weekend behavior. When allowed to sleep without external restrictions, he sleeps from 2 a.m. to 10 a.m. During these days, his total sleep duration and sleep quality are normal, and he wakes up feeling rested. This graph illustrates delayed sleep phase disorder. The shifted wave shows a misaligned circadian pacemaker. Falling asleep easily eliminates psychophysiological insomnia. Avoiding late caffeine rules out inadequate sleep hygiene. The late-night delay makes advanced sleep phase disorder incorrect. The 2 a.m. onset eliminates non-24-hour sleep-wake disorder. Management involves resetting the biological clock through exposure to bright morning light, gradual adjustments to his sleep schedule, and melatonin in the early evening. Identifying this as a circadian misalignment rather than true insomnia ensures this pediatric patient receives chronotherapy rather than inappropriate sedative medications. A 4-year-old boy presents with a fever lasting over 7 days, bilateral non-purulent conjunctivitis, fissured lips, and a polymorphous rash across his trunk. This anatomical map connects his symptoms. Adding extremity edema and cervical lymphadenopathy fulfills the criteria for Kawasaki disease, a medium vessel vasculitis. If left unchecked, systemic inflammation attacks the coronary arteries, structurally weakening the medial wall and creating a high risk for aneurysms. We can eliminate tick-borne illnesses like Rocky Mountain spotted fever. The exposure timeline does not fit, and RMSF typically lacks the lip fissures or extremity swelling seen in this patient. Scarlet fever is ruled out by the lack of conjunctivitis and extremity edema. Measles is eliminated by the absence of cough, coryza, and Koplik spots, the characteristic white lesions inside the mouth. The first-line therapy is prompt administration of IVIG, intravenous immunoglobulin, paired with high-dose aspirin to target the inflammation and prevent thrombosis. Administering this immunomodulatory therapy within the first 10 days of illness is not about controlling the fever or the rash. It is a critical prophylaxis against cardiac structural failure. A 58-year-old woman experiences gradually worsening pain and stiffness in her knees and fingers. The pain exacerbates after physical activity, and her morning stiffness lasts only about 15 minutes. This skeletal diagram highlights her specific physical findings. She has bony nodules on the distal and proximal interphalangeal joints, known as Heberdin's and Bouchard's nodes, along with crepitus and mild genuvarum, or bow-leggedness, indicating medial cartilage thinning in the knees. This clinical picture defines osteoarthritis, driven by mechanical cartilage degeneration and bony hypertrophy, lacking systemic inflammatory markers. The brief morning stiffness under 30 minutes and specific involvement of the distal finger joints strictly rule out rheumatoid arthritis, which causes prolonged stiffness and spares those joints. Acute monoarticular conditions are also eliminated. They present with single, red, acutely swollen joints, which conflicts with her bilateral, chronic bony nodules. Definitively identifying mechanical degradation protects the patient from the unnecessary use of aggressive, systemic disease-modifying anti-rheumatic drugs that carry heavy side effect profiles. As a jagged crystalline formation forcefully distends and scrapes against the soft, pulsating lumen of the ureter, it causes microscopic trauma and immense referred pain. A 29-year-old pregnant woman at 30 weeks gestation presents with acute onset, severe, colicky right-sided back pain. Her urinalysis reveals microscopic hematuria, or blood in the urine. This view traces her pain radiating from the back to the groin. This pathway, plus hematuria without pyuria, points to nephrolithiasis. The absence of fever rules out pyelonephritis. Her high flank pain eliminates appendicitis and ovarian torsion, which present lower in the abdomen. Diagnostic management must respect the patient's gravid context. Because she is pregnant, ultrasound is the preferred imaging modality over a CT scan to avoid exposing the fetus to ionizing radiation. Recognizing the mechanical nature of the obstruction allows the clinician to bypass broad-spectrum antibiotics entirely and prioritize a safe, targeted imaging approach. This endoscopic view shows an incidental finding in an asymptomatic 64-year-old woman. The Z-line, where the esophageal and gastric linings meet, is displaced abnormally high above the diaphragm. This displacement indicates a sliding hiatal hernia, a common structural shift where part of the stomach moves above the diaphragm. The critical detail lies in the biopsy histology. The epithelium contains gastric columnar cells, but strictly lacks goblet cells. The absolute absence of goblet cells rules out intestinal metaplasia, meaning there is no evidence of Barrett's esophagus. Because there is no pre-malignant transformation, routine surveillance biopsies are unnecessary. The appropriate management is conservative lifestyle advice and reassurance. Because she has no symptoms of acid reflux, initiating proton pump inhibitors or considering a surgical fundoplication is unwarranted. Identifying a purely structural shift without histological transformation protects an asymptomatic patient from a cascade of unnecessary pharmaceutical prescriptions and surgical interventions. This unified matrix combines the diagnostic logic from all 6 clinical presentations. Notice how the positive symptoms initially create a web of overlapping, conflicting possibilities. The definitive breaking points for the incorrect assumptions rely on the negative findings: normal oxygen saturation, normal weekend sleep architecture, the absence of goblet cells, and the lack of pyuria. These missing data points sever the pathways to incorrect therapies. Effective differential diagnosis requires equal, if not greater, attention to the markers that are conspicuously absent from a patient's presentation. Pinpointing the precise mechanism, be it immune alloimmunization, circadian shifting, or medium vessel vasculitis, differentiates generic symptom control from targeted, life-saving management. When faced with complex, overlapping medical presentations, you must actively seek out and leverage the negative clinical notes. They are the strongest anchors to clear the noise and map your reasoning to the truth.